I just start by, as Stuart has done, just acknowledging that I too am on Whadjuk Noongar Budja and pay respects to the traditional owners and custodians of the land we're on, and acknowledge that, you know, in Western Australia, 48% of the prison population are First Nations people. So it's really kind of relevant and poignant that that we pay that acknowledgement, because they're so present in what we do. So I'm just going to give you a little bit of an overview of the office. Some of you may or may not know what we do and our jurisdiction. Then I'm going to talk a little bit about the prison population and the challenges faced across the adult and youth prison, before I then go in and provide some more information, more detail about health and mental health in prisons, which I think is probably what you're used to. So if there's a bit of repetition of information that you're already across, I just apologise for that before we start. So the Office of the Inspector of Custodial Services is an independent statutory agency. We were established in late 1999 and been going and got our own piece of legislation in 2003. I'm independent. I don't report to the Minister. I have a relationship with the Minister. I don't report to the Department of Justice. I'm appointed by the Governor, report directly to Parliament. So when we table a report, it goes direct to Parliament. You know, obviously we have to consult and give people an opportunity to respond to reports and draft findings and that kind of thing. But I'm not beholden to anybody, which is quite liberating when you're in an independent role like this. Just on the bottom of the slide there, you see we're also been nominated as one of the national preventative mechanisms for OPCAT, which is the United Nations Optional Protocol for Convention Against Torture and Cruel and Inhuman and Degrading Treatment and Punishment, which is a bit of a mouthful, which is why we use OPCAT all the time. But essentially, that's an international obligation for Australia and all the jurisdictions within Australia to set up a process of oversight monitoring of places of detention. That's another presentation all of its own, so I'm not going to go into any more detail on that. So I've got a kind of three limbs to what I do, or to my role and to the role of the staff we've got here, and that's inspections, reviews, and running or managing the independent visitor service. Under the Act, I'm obliged to inspect at least once every 3 years prisons, youth detention centres, court custody centres, and that includes 4 police lockups that are prescribed as court custody centres for periods of the day. But we also have a power to do what's called occasional inspections and reviews of custodial services, which are the thematic reviews. So things like, we've done a review on older prisoners, smoking in prisons, and those sorts of things. They're the reviews of custodial services. The occasional inspections allows us to essentially maintain monitoring and visit prisons within that 3-year period. So we're not going out there just once every 3 years, which is really important. Yep. I've got a range of powers. They're all set out in the Act, but you know, the Act says it uses some really useful terminology. It says can do all things necessary and convenient to be done. So there's really no ambiguity about that, about what we can and cannot do. It avoids any sort of argument about, you know, the security of the prison. You can't bring this in or that in. But having said that, you know, we're very practical and we work closely with security. So in other words, we can take in phones and laptops, but we don't, by practice, take them around the units. We might keep them in the administration area and keep them locked away. I also have another interesting terminology: free and unfettered access to custodial places. So that's prisons, people in custody, people working in custody, vehicles, the department systems, processes, information and documents. And that includes contractors, including the private prison operator, Serco, which operates Acacia Prison. We can't be denied entry to a facility. So and we have recently in the past couple of months, I suppose, done one unannounced night visit to a prison and one announced night visit. So we just told them we were coming. And the unannounced one, we went to Hakea Prison, which is a source of great concern to me at the moment. But by agreement, we agreed to our bags and our materials to be searched when we enter prison. That's fine. We've really got nothing to hide. But if there's a concern and they wanted to do a more invasive search, then obviously we have protocols to deal with that. And just on the bottom of that slide, there's a bunch of I suppose enforcement or penalties, for someone who might inhibit what we're trying to do or victimize people we deal with and that kind of thing. So a broad jurisdiction and very broad and very useful powers. It's just a little bit of give you an idea of the size and population of the prison system here in Western Australia and some of the key challenges that we're facing. So just for adult, I took these numbers. I get a daily update every day, but on the 20th of March, there were 8,371 people in prison in Western Australia, 7,500 men, nearly 900 women, and about 46% of the population are Aboriginal. 41% of the prison population are held on remand, so it's 3,391 remand. You'll see on the screen, there's a high percentage of women held on remand compared to men. And that population has increased by 33% between January 23 and March 25. So it's an incredible increase, about 15% increase for the last 2 years. So you can see the numbers there, 6,300 to 8,300. So our largest prison in Western Australia is about 1,600. So it's our largest prison plus some. And the increase in population is driven by an increase in the remand number. So the percentage of total remand's gone from 35 to 41. So it's a really large number. And on the bottom of the screen there, you see most of the adult facilities are at or above their maximum capacity. So 14 prisons are at above 93% capacity and 9 were over 100% capacity on the 20th of March. Which means that there's about 350 men and women, 330 men, 20 women, sleeping on a mattress or a trundle bed on the floor of a cell that's already double bunked. So it's a pretty dire situation. In the youth population, in the youth estate, the numbers are a bit different. As at the 20th of March, there were 74. Mainly young men, 72, and 2 young women. The number of young women and females in prison, it fluctuates. It can be sometimes as high as 8, but generally we find it's somewhere between 2 and 5. 67% of the young people are held on remand, and you'll see the population of the youth population fluctuates. And there's a little table there on the screen. It's been as high, 4 or 5 years ago. 120, 130, and it's down to an average. It's been as low as 60, 58, it's sitting at about 74. So it fluctuates a lot. I have a view that I think the youth population right now at 74 is a bit low. It's a bit artificially low. I don't have any scientific evidence of that. It's mostly anecdotal, from my conversations with the courts and from conversations with people in custody. But that's not a bad thing because it means that there's a greater focus on a diversion, a greater focus of supervising kids who can come into contact with the justice system in the community and that kind of thing. So I'm certainly not advocating for a greater rate of incarceration. 74 is a good number. If it continues to trend down as it is, then there'll be no one happier than me. And you'll see just on the bottom there, the average time in detention is about 30 to 40 days, which is really important, particularly when we get talked to health, because as all of you will know, what can you do by way of influencing health outcomes in 30 or 40 days? So that's an interesting one. Major challenges facing the adult population or the adult prisons. And this is what we've seen consistently over the past 5 to 10 years in our inspection and review work. In the last 3 years, say post-COVID, record prison populations. I've just spoken about that, so I won't go into that anymore, except to emphasize that when the population is really high, it impacts every single aspect of the prison life. There are more people trying to get out to recreation. There are more people trying to get to the phones, to visits, to health, to appointments, to find work. It impacts everything. Prisons in Western Australia, like prisons in almost throughout the world, but certainly in Australia, are often inadequate and outdated infrastructure. So the last time we built a prison in Western Australia was about 10 years ago. I'm not advocating for new prisons, but they do wear out, and they do need to be renovated or updated or modernized. And there's sort of struggles there. Staffing issues, probably the biggest issue alongside population. Staffing issues is an enormous challenge. Both vacancies, so in other words, positions they can't fill, and absences. So, workers' compensation, approved leave, not approved leave, daily absences has a huge impact. And then the last point there is inadequate mental health. And I'll talk about that. And that's pretty much across the system, but I'll talk about that in a little more detail in a moment. As far as youth detention, but I think many of you will have seen and heard about the problems we've had with youth detention in Western Australia over the past 2 or 3 years. And I'm probably not going to talk about that so much because it's been well documented and it's been covered in great detail throughout our inspection reports. So what I wanted to do, I suppose, is talk a little bit more about where we are today and where we're going to. And just before I do that, if you hear some noise in the background, there's a protest of trucks driving down the street that my building is on. So if you hear that, it's not normal, but just a little bit of a rider there. Hopefully you can't hear it. So challenges in youth detention. So they've embarked on a recovery period from the recent periods of crisis and instability, as I was just saying. They're following a significant reform agenda. They're implementing a new model of care. They're having a greater focus on Aboriginal engagement and developing a cultural framework, doing partnerships with external organisations, so in-reach services, community organisations, Aboriginal health organisations, and cultural organisations. So they're doing a lot of positive work, but it's early days. But I'm certainly keen to give credit where credit's due. They have moved quite significantly, both in resource allocation and in what they're doing, and in a cultural shift. But one of the other challenges is the complexity of the population from a health and welfare perspective. So many people come into custody in Western Australia, young people, with such complex presentations, both from a life perspective, but also from a health and welfare perspective. And then, as I mentioned before, the high rates of turnover in the detention population. So that kind of paints a bit of a picture, and hopefully not too bleak a picture, but bleak is a word I use quite regularly, as is crisis, which is another word I use quite regularly, and I think with good reason. So health and mental health in prisons and youth detention. So just generally in health in Western Australia, I'm sure you can hear that now. No, well, that's fantastic, because it's really quite loud. So in Western Australia, the Department of Justice is responsible for the provision of health in prisons, which is unusual. I think we are the only jurisdiction in the country now that the Department of Justice is responsible for health service provision. And I'll get to that at the end. But people in custody, who are in custody or come into custody, have complex health needs and have often experienced poor engagement in the community with health and healthcare. I've heard many occasions, particularly in remote communities, where the health staff say, we get these people come in from the community that they live and know, and their health, it might be, for example, their diabetes is totally unregulated, and they come in and they spend 12 or 18 months in prison. They get that regulated, they get on regular medication, they have a more healthy lifestyle, a more healthy diet, and they get released, and then they go back and don't maintain that level that they've built up, which is kind of like a revolving door. People in custody are more likely to have higher rates of chronic disease and long-standing physical and mental health issues, and it's often exacerbated by an ageing prison population. The prison population in Australia and in Western Australia is ageing. And there's some data down on the bottom there that was provided to me recently by the Department of Justice. It's not something I've verified, but in that they said that the 42% of the entire population had been diagnosed with a chronic condition, 47% diagnosed with a mental health condition. And I think they're using a pretty broad definition. It could be cognitive impairment or whatever, but and then 22% were diagnosed with both. And then the last point I think is probably true. There's a significant or an anticipated underreporting, because often people someone might have a disability in prison and be in prison, and the only way it's disclosed if they self-disclose this, because there's no diagnostic assessments. So the model of care of healthcare in prisons is what they call a nurse-led practice, and I apologise to those of you who are familiar or who are clinicians if this is a very much a layperson's description, and I'll probably use all of the wrong terminology, but so if I offend anybody from a professional perspective, I apologise in advance. But a nurse-led practice, it sort of generally works well for the routine stuff. But of course, it's always subject to adequate staffing. So where prisons have a health service they have a clinical nurse manager, regular attendance of a medical practitioner, and sufficient nursing staff to do daily medication rounds and run clinics and that kind of thing, it generally works pretty well. Not so much in regional prisons, because in regional centres, it's far more difficult to attract and retain staff. Generally, it's not a culturally safe model, and that's largely due to the absence of Aboriginal clinical staff, Aboriginal nursing staff, health Aboriginal health workers, and that kind of thing. So that I think that's a fair statement across the system. In the initial health request by people in custody, they're initially triaged by the nurses, and that often causes some conflict, because particularly men will say, I don't want to see the nurse, I want to see the doctor, but they're triaged by the nursing staff and then listed for an appointment with the doctor. There are issues with timeliness of access to medical practitioners and specialist services. So, sometimes people can be waiting weeks just to see the GP, and months or sometimes years to see specialist services. Appointments are often via telehealth, and I know that's improving, and it works reasonably well. Surprisingly, I've spoken to psychiatrists and mental health workers who say that it's far from ideal, but it works, and it's kind of like better than nothing, I guess, which is pretty bleak state of affairs in a sense. But so appointments by telehealth are not entirely negative. It's sometimes better. And then, as I said previously, the ongoing challenges with the attraction and retention of clinical staff, particularly in the regions. They'll often have nursing staff who are agency staff or who are on short-term contracts. So it could be people who are travelling and they're in a particular place for a period of time. All right. So one of the things that is very poor in prisons is dental care. There are a few notable exceptions to that, but dental care is very, very poor in prisons. Long wait lists for treatments, very limited treatment options, and they're common complaints we hear from prisoners. I mean, I was in a prison recently, or towards the end of last year, and there was a fellow whose face was swollen, like, as you can see on my screen, almost that size. I thought he had been assaulted, and I said, "What's wrong with your face?" And he said, "Oh, I've got a problem with my tooth." I said, "That looks bad." And I said, "How long have you had it?" And he said, 9 months. They've been waiting, and so they just couldn't get an appointment. There wasn't a dentist in the town. The dentist had to come from a town 250 kilometres away, and they run clinics for the community, for the town. And as far as getting out to the prison to run a clinic, it was very low down on the list. And meanwhile, this fellow had a dental complaint, and it wasn't being tended to. And then the last point on that dot point, general health staff are left to manage the symptoms, with pain relief, with antibiotics, and those of you who have some clinical knowledge will know that poor dental hygiene and poor unmanaged dental disease can have catastrophic impacts on your health. Heart disease, blood infections, all sorts of things. So dental care in prisons is pretty average. And one of the reasons for that is that dental care is provided by the Commonwealth with funding to the states, and then the state it's the public dental system. So public dental system is not great in the community, but it's a lot worse in the prison system. But like I said, there are some exceptions. There are some exceptions that have prisons have a dental suite, they have a regular attendance of a dentist. Private prison, Acacia, which is on the outskirts of the Perth metropolitan area, run a good dental service. There's wait list of a week or two, and they do restorations. Often in the public dental system, by the time they get to see a dentist, the only option is a extraction, which is pretty poor. Like I said, the regional and remote prisons experience greater challenges in service provision because there are limited services available in the community generally, and even more limited. Mixed infrastructure across the custodial estate, and the availability of custodial staff is also, pardon me, a big problem for the health services, because for health services to run, it has to have custodial staff there to maintain security and safety. And so if they're short on custodial staff, sometimes the clinics are suspended or cancelled. Allied healthcare and our access to specialist care, it's again a bit mixed. It suffers from a lack of structured and consistent access. And what I mean by that is that structured access is there is a system of, there's a clinic that runs, and it's not Fred needs to see the specialist and we'll try and get him into an appointment. There is a regular structured process by which that happens. Consistency of access, it's not an uncommon problem that we hear. I waited 9 months for an appointment, and then on the day there was no one to transport me to the appointment, and I missed the appointment. And so that has two consequences. The person goes back on the list to try and get an appointment. There's a lost appointment in a public health clinic for whatever service, and so it has lots of impacts. I've spoken about the dental care. The adult health care is often dependent on local relationships, particularly in regional areas and regional prisons. So the clinical nurse manager will build up a relationship with a local regional hospital, and on that personal one-to-one relationship, say, yeah, we can do that. We can, if you bring your guy in on a Tuesday morning, we can set aside the first hour for 2 or 3, that kind of relationship. But it's not a structured relationship. It's built on that local relationship. So those people leave, and the relationship sort of falls away. But that said, we do come across many prisons where they have really great staff, and what I'm saying now is not a criticism of the people who work there. I take my hat off to them. In fact, they have a great process where they have like regular annual health checks, monitoring ongoing chronic diseases, monitoring medication and medication compliance, age-related health checks. As we all get older, we need to have probably more monitoring testing rather than diagnostic testing. So there are some prisons that do that really well, and others that not so well. Access to the NDIS is or disability support is often lacking. I think it's starting to improve. They're starting to get better engagement and placement or regular visiting from NDIS providers or NDIS case assessors and whatever, but it's still pretty poor. People with ongoing or previously diagnosed disability in prisons do tend to struggle to get the support they need. And as I've said, I won't labour the point, it's often more difficult in regional and remote areas. One of the biggest problems facing health in prisons is just the attraction and retention of clinical staff. I'll talk about this in a little bit more detail when I get into mental health, but they can't offer comparable conditions of employment. Workload demands are high. There's like particular challenges with specialists and mental health and AOD staff. Psychiatry, mental health and clinical governance leadership face critical shortages in the adult custodial state in Perth right now. I think they've got maybe one psychiatrist available to do all of the mental health. They might have a couple of consultant psychiatrists who run sessions, and they struggle to get mental health and clinical governance leadership. So, it is in a pretty difficult spot right now. Clinical infrastructure, as the population has aged, the size of the health centres hasn't expanded generally. So there are cramped workspaces, shortages of clinical spaces, and limited staff amenities. We see staff with a tea room in the same place where they store the cleaning materials and all sorts of things. So it's kind of like it's not an attractive work environment. We're about to release in a week or so a review report on crisis care infrastructure, but it's generally it's either not available or it's inadequate. And that review, the results of that review will be available on our website. I think on the 10th of April is the day it's being released. But generally, crisis care, we often during our inspections will bring an expert, either a forensic psychiatrist or a mental health expert or a general health expert, and they often say that the crisis care centres are bleak and certainly not therapeutic. And again, the problems are far more profound in the regions and remote locations. But it's not all bad news. There's the Department of Corrections has developed the Bindi Bindi unit at Bandiat Women's Prison, which is a notable exception. That's a step up, step down. It's an old unit that they renovated quite considerably. So it's a bit of a step up, step down for people who are having issues, mental health crisis, or to try and I suppose cater for their particular needs. They do have difficulty, like all the prison system do, staffing it with clinicians. It's a unit where the clinicians and the custodial staff sit side by side, so that's probably that's quite good. And then there's some infrastructure being developed at Casuarina Prison, which is the main maximum security male prison here in Perth. They're expanding the infirmary, they're building a new crisis care unit and a new dedicated mental health unit. So that mental health unit is likely to be a place where people who are held under the criminal law mental impairment legislation are held. Mental health in prisons is a bit of a bleak story, I'm afraid. Shortfalls in mental health services and infrastructure are common. I've spoken briefly about the crisis care centres, but just to give you some idea of the size and scope of the problem, approximately 8% of the prison population, so it's about 650 or so, of the adult prison population have or are awaiting an assessment for a diagnosed psychiatric condition. So that's just a treatable mental health condition. That doesn't cover neurodevelopmental problems, other forms of disability that reflect behaviour and how a person copes. So that's just a diagnosed mental health illness. Now, in January 2025, 32 adults were held in prisons which were in the top category. The department categorises them into 4 categories: P1 to P3, and then PA is those awaiting assessment. So P1s are people who have a serious psychiatric condition requiring intensive or immediate acute care. To give you a perspective, in the community, they would be put on forms and taken to a hospital for assessment and treatment. In the prison system, that place would be the Franklin Centre, which is the only secure forensic hospital in Western Australia, which only has 32 beds. And generally about 10 or so are available in the prison system. So those 32 are people who are waiting for those potentially 10 beds. And generally those 32 would be held in crisis care facilities, which are basically, as the last point on the slide says, focused entirely on prevention of self-harm, serious self-harm and suicide. So it's very difficult. They would be seen by a clinician for maybe half an hour to an hour a day, and then the rest of the time they're largely held in isolation, managed by custodial staff who do their absolute best mostly. But it's pretty bleak. I use that word bleak again. And so the focus for mental health in prisons, sadly, is largely risk management and the prevention of suicide and self-harm, either through reviews, monitoring, or people who are at risk. But having said that, that process of what they call the prisoner at risk process, either the prisoners on at-risk monitoring or ongoing less invasive monitoring, works okay. I won't say it works really well, but it works well enough. Youth detention is something of an exception. That's, again, youth detention, health in youth detention has turned a little bit of a corner. It's a general and nurse-led practice, but the staffing is generally okay. It's had its ebbs and flows, but it's not too bad at the moment. Shortfalls in diagnostic assessment on entry are being addressed, and that was one of the big concerns that we had when we wrote a lot about the situation in youth detention in Western Australia. But since then, a lot has changed. They're developing a new model of care, which is a trauma-informed model of care. They've got a really great partnership with the Child and Adolescent Forensic Psychiatry Service, and they have in-reach clinicians every day from that service. They've got improved collaboration and cooperation. They're still trying to work out, who sits where and who leads which dance and that kind of thing, but it's certainly improving. And one of the big things that they're doing that we advocated for was they're doing initial diagnostic assessment on entry. So that's actually quite good. So and where there is an identified need, they're making referrals for more complex diagnostic assessments. So the service provider that's coming in and doing those assessments are the service providers that they would need to be in touch with in the community. So there's that better through care pathways. Bearing in mind that the kids held in juvenile detention are probably only there for 30 or 40 days. So it's that opportunity for to get some stability, to get some diagnostic, and then get some links for when they're released. And there's a smaller percentage, obviously, who are sentenced to longer periods. But we find those young people to be far more settled and far more, I suppose, less likely to act out or that kind of thing. As I said, there's a new model of care, so trauma-informed model of care, which is actually really good. But that is like a cultural shift that is going to take several years. That's not something that you do overnight, but they're working positively on it. And all of that, it's building on the TKO research that many of you will be familiar with about the prevalence of the FASD and other neuro conditions in Banksia Hill, which was done in 2018, which was quite an amazing piece of work. So they're, in the youth centre, they've turned a bit of a corner. They're probably, if you imagine on a journey, they're probably much further ahead than the adult system. And just the last line there, they're building or constructing a crisis care centre at Banksia Hill as we speak. Well, I was out there last week, and they're lifting up. It's the facility starting to get walls, which is really good. And that'll be a dedicated place where young people who are having a crisis are able to go and be cared for in a therapeutic way rather than in a custodial way. So that's quite a positive. So I got a briefing recently with the Deputy Commissioner and one of his senior staff about where they're going and what, I spent most of the time talking about the problems, but they're not the department are not sitting along blithely ignoring the problems. So they are aware of it. We've had many conversations about it, and they recognise the challenges they face in health. You know, record populations and demand. They understand the need for improved clinical governance, adequate funding of services, better integration of services, and the infrastructure limitations. They've developed, and I can't share too much with you because it was shared with me in confidence, but they've developed a new model of care which puts the patient at the centre, providing holistic, evidence-based, culturally responsive care. That's the terminology that they use. But they're terms that'll be familiar with most of you about, you know, the kind of thing that's ideal, that works in the general community, that if all the different disciplines talk to each other, if it's culturally safe and responsive, and if it's evidence-based, you know, you're likely to have much better outcomes. And that's what they're trying to move towards. And they're also restructuring the health and mental health in prisons, not that they don't always sit comfortably together, and they have been separated and they've been brought back together again, and separated and brought back together again. And, you know, obviously at some points there has to be a clinical lead for across all of those things. And there's often professional sort of concerns about my clinical lead is a non-mental health practitioner, or my clinical lead is a non-general health practitioner, and there's all sorts of things. But I don't think they're insurmountable problems, quite frankly. But so there is a move to bring all of health, mental health, AOD, counselling, all under one umbrella, which I actually think will be good. But I suppose and just in conclusion, I started by the presentation by saying that the Department of Justice is responsible for the delivery of health in Western Australian prisons. And I'll end with posing a question on it. It's a bit of a rhetorical question, but should the Department of Health run health services in prisons rather than the Department of Justice? And on that note, I'm quite happy to take questions.
Thanks very much, Eamon. That was a fantastic overview. And although you're speaking about the West Australian system, I'm sure it will resonate with people in other jurisdictions as well. We do have some time for questions, so I'll invite people to put on their camera if they wish. It's great to see some faces and ask any questions. I see, Cameron, you were first. You had some questions in the chat, or if you'd like to read those out or ask those.
Yeah, thanks, Stuart. The first one I was just asking was, besides reporting on issues in WA custodial services, does your office adopt certain positions? For example, with the overcrowded prisons, do you either advocate construction of more prisons or decarceration of the less serious offenders and those on remand?
Yes to all of the above. You know, we will regularly advocate for, you know, we don't focus just on health. So we'll regularly advocate for, you know, diversion, you know, alternatives to prison. We'll say, you know, the prison system's full, so you need to build new infrastructure, or you need to get people out of prison. So in other words, give them programs, give them treatment assessments, get them parole ready, get them, you know, there's lots of people who are in prison who do their full time, and yet if they had a proper treatment assessment and they were given an adequate program, they would have likely to have been given parole. There's, you know, accommodation on release, employment on release, all of those things will impact on prison population. So it's not just about building more prisons, we advocate for a whole range of solutions.
Yep, that sounds how it should be. So, the second question was just regarding inmate reports of justice health issues. Does OICS merely aggregate all the reports, or do you have the resources to actually get back to the individual prisoners to describe the progress that's being made?
Okay. So as far as reports, if I understand the question correctly, prisoners don't report their health concerns to us per se. we would have access to that data. So if a prisoner has an issue that they need to see a clinician, they put in a form or they put in a request to the health centre. And it goes to that. What we do is we come in and look and how effective is that? Is that demand being met? Are there clinical services available? We bring in an expert, might say that the quality of those clinical services, not individual quality, but generally, they're not meeting clinical governance standards and those sorts of things. We don't actually, and my act actually prevents us from actually dealing with individual complaints.
Yeah, that probably leads into my last question, which was just how you work in with the WA Ombudsman and other official prison visitors.
Yeah. Well, we've got a pretty dedicated or defined legislation and jurisdiction. I'm in the same building as the Ombudsman. I meet with them regularly, as I do with the Freedom of Information Commissioner, the Commissioner for Children and Young People. The Auditor General has a role in prisons. And we talk generally, like if the Ombudsman was going to do something in prisons, and they deal with complaints in prisons all the time, they have access rights the same as we do. They might often come to say, well, what do you know about, this decision or this practice or whatever? And we'll often do the same thing. The Health and Disability Complaints Officers here, we'll often say, we're going to a prison, we're going to do some work around health complaints. What data have you got? What information do you have? And so there's, and again, that's structured, but it's also on a personal level. There's a cooperation.
Yeah, terrific. Thanks very much, Eamon.
Thanks, Eamon. We've got plenty of questions. I think it's Matt, then Lindsay, then Kelly. Matt, over to you.
Thanks, Stuart, and thank you for the presentation. I've got two questions, if that's all right. The first is, I'm just wondering where you are with lived experience perspective. So I've done quite a lot of work with the Scottish Prison Inspectorate. I used to volunteer with them. They're doing some really interesting things around, they have a lived experience advisory committee in the first instance, but secondly, they're trying to involve people with lived experience within the inspection process. And thirdly, this is the slightly more radical approach that they're discussing, but they haven't implemented, is actually involving people from different institutions in inspections in other institutions. So people who are within the prison system actually involved with the inspection process. So I'd love to get your reflections on those sorts of, I guess, innovations and where you are with those sorts of things.
Well, I guess just the starting point is we have people on staff here who have worked in prisons, and we have a community liaison officer who is an elder within the community. So we have that connection. As far as lived experience, it's something we've talked a lot about. We've looked at. We have an agreed policy and practice by which we would engage with lived experience people. For example, just simple things like we would remunerate them for their time, and we've got a rate and a means to do that. So we would do that in, our plan is to have, community consultation type forums. So there might be an issue, we're looking at a particular thematic review of something, and we might want community consultation lived experience. There are a couple of challenges. The other thing, we have independent visitor service, and they're community volunteers who are appointed by the minister and go into prisons. And some of those have lived experience, not necessarily from personal incarceration, but family members and that connection. It is more difficult with bringing lived experience people in on our teams and to go into prisons, not from our perspective, but from the perspective of the prison, the security and, this is a person who was in jail 2 years ago. Oh my God, something bad might happen, but it is certainly something we've looked at. We've spoken actually to the Scottish inspector, to the UK inspector, the New Zealand inspector, and it is certainly something that we're working on. We're in the middle of implementing a new model of operation. And one of the things this is phase one. One of the things we're looking at in phase 2 and 3 is exactly what you're talking about, try to get that better engagement with people with lived experience. It's so important. We, through our community liaison, we talk with people in custody and who are people who are released from custody all of the time. But I think it would be fair to say that it's something we could probably do a bit better.
Thank you for that. And I just have another quick question, if that's all right. I've got a PhD student back in Scotland whose PhD is specifically focusing on the legitimacy of the inspection process. So his methodology is that and he happens to have lived experience. He is going into prisons after they've had a full inspection and just hanging out with prisoners to find out what their engagement was like, what their perception of the process was like. And really it's about, and it's quite early on in the process, but he's really showing some really challenging insights in the sense that people in prison, at least in his study, very much perceive people from the inspection process as part of the system, as part of the prison system. And you mentioned having some former maybe prison officers or prison staff working for you. Certainly from my PhD student's perspective, that's quite problematic in terms of the independence and the legitimacy of the process from the perspective of people in prison. So I wondered if you could reflect a little bit on, if you're in a prison, a few people in suits come in, you're thinking they're senior people from the prison, and I wonder if you could reflect on some of those kind of entanglements, I guess.
I do. I'm wearing a suit and tie today. I'm only wearing a tie today because I have to appear in court straight after this. But I never wear a suit. We never wear suits when we go into prisons because you look like a lawyer or a policeman, but most people in prisons have had bad experiences with both. We spend a lot of time talking with prisoners. We're about to release a report next week where we have an extract from a prisoner letter. We received a letter about conditions in Hakea, and we've actually published with his consent. We sort him out. So we do try to engage, but we are part of the system. I'm a public servant. I'm an independent public servant, but I'm paid by the system. So I guess it's how you do that. We spend a lot of time engaging with prisoners, just hanging like your PhD student, hanging around in the units, sitting down in the day rooms, and you start, one or two people will come up to you and they say, what do you guys do? What are you here for? And we tell them, and we always tell them we're independent, arm's length, and then before you know it, you've got a crowd of people around you, just talking, engaging. We often, and this is probably indicative, we often get said, the staff say, you're only here for the prisoners. So pretty much everything we advocate for is to improve the system for prisoners. But I accept your point. It's a valid one. Anyone who goes into prison has to have some kind of authorization from the government to do it. They've got to go through a security check, got to go through some sort of vetting. So are they truly independent? Do we throw the prison open? So it is a real challenge. And one of the things we try to do is we have T-shirts that have particular branding. We always talk about what our role is, and that we're independent. Our community liaison officer, particularly with Aboriginal people in prisons, is fantastic. He's been with us for 20 years. Every prison he goes to, he's known. Doesn't matter whether it's in the metropolitan area or out in the regions. So yeah, it is a challenge. But the reality is we are part of the bureaucracy. We can't get away from that. We can't hide or pretend that we're not. We are part of the official bureaucracy. And I guess in an ideal world, there would be access for advocates who are independent, work at non-NGOs, and they would have access to prisons. They advocate strongly, but often it's from outside the walls.
I feel like this is a conversation that could have gone for much more than the hour that we have, but thanks, Matt, for some excellent questions, and Eamon, it's very complex. Look, I'm mindful of time. I want to make sure that both Lindsay and Kelly have an opportunity to put their questions as well. Lindsay, if you try to be as succinct as you can so we can make the best use of time.
Yeah, sounds good. Thanks so much. I really enjoyed that, and I'm glad you peppered in some positive stories. I went into one of my first prisons last week or the week before, and the word that came to mind was bleak. So I think you were pretty spot on in my mind around that. My question is just around the recent federal budget that was released, I think this week, that essentially, maybe Kelly had the same question, that omitted OPCAT funding to the states and territories. And I've been involved in a group that's been engaging with the Department of Justice and Community Services of Victoria and basically having the same roundabout conversation every 4 months or 3 months that they're waiting for funding commitment, and obviously it didn't happen. So there's just a bit of a stalemate because they don't want to move forward. And I'm just wondering, obviously you guys are doing an amazing job in WA, and I'm just wondering if you can describe, is that connected to that federal funding or at all, like the initial funding that was offered? And I guess I'm just curious because, you know, can Victoria and other states and territories be doing a better job? And is that excuse that they've been giving us every quarter just a point?
Well, I guess Victoria is one of the states that doesn't have a prison inspector. So that work is left to people like the Ombudsman or the Auditor General. So there isn't, I don't have an equivalent in Victoria. The OPCAT funding from the National OPCAT network, which is coordinated by the Commonwealth Ombudsman, put out a statement. I think it went out yesterday on the lack of funding in the budget, in the Commonwealth budget for OPCAT. OPCAT for us, what it'll mean is our jurisdiction that we have right now that I've spoken about inspecting prisons and youth detention and all those sorts of things, that exists already in state legislation, and I'm funded by the state government to do that. When OPCAT is fully operational, I will also have jurisdiction over police lockups. So there'll be 150, 160 additional facilities that I'll have jurisdiction over. What I'm supposed to do, how I'm supposed to inspect, how I'm supposed to report, all of that will take a team of people, and that's the funding and resourcing problem. I don't think we are looking for funding for what we're currently doing. What we're currently doing will be captured by OPCAT. And you know, and there is a standoff between the states and the Commonwealth, and we're doing a lot of work on OPCAT. You know, as part of the national network, we're doing policy commentary, we're attending training, we're providing training and that kind of thing. But we're not funded to do it. We're just doing it from the resources that we have.
Well, good work. It's nice to see.
Thanks, Lindsay. Thanks, Eamon. Last question, I suspect, is going to you, Kelly. Please go.
Thank you. So I'm actually with the Commonwealth Department Health of Aged Care, and this has been extremely helpful for me to just listen to and learn from. My whole bread and butter is actually the recent national review for First Nations healthcare in prisons, and something that I was really interested in. And it's probably a much bigger conversation than we can fit into 4 minutes, but just I guess how much involvement or reflection you, Eamon, have had perhaps with the review and with those recommendations, which are really big, really ambitious, and call for a lot of interjurisdictional cooperation. So I was just keen for some I guess an initial reflection.
Well, I guess I think it was mid last year I participated there was a round table here in Perth. I think there was a series of them, but I was lucky enough to be invited to one. So we had some contribution there. And I'll be honest with you, I haven't had a great level of engagement since that. You know, we've had obviously the report or the synopsis of those workshops circulated, which has been great. I haven't done anything or said anything publicly about all of that because that's a body of work someone else, you guys, are doing. But that was really good. And there were in that work roundtable that I participated with, there was representatives from all the different players, I guess, which was quite good. The health outcomes for First Nations people are pretty or are below what we'd all like to see them. That obviously the closing the gap targets are falling short. It's probably worse in prisons, and can people say prison health services and outcomes should be comparable to the public health service and outcomes? I actually don't think they should, because I think the people in prison, if from the health, they're on the peak of the triangle, so they're probably of a much higher need. And we found this in a review of dental services. People were saying, oh, comparable dental services in prisons compared to the community. No, because the people in prisons have far higher need and far more intense needs. So, I think that's something that we can't just say, oh, well, it's the same sort of services available in the community. Well, no, this is like intensive care rather than like a general ward. So I haven't really answered your question very well. I'm sorry, but
Thank you. It's a big conversation.
Yeah, and I feel like this is another conversation that we could have spent the entire hour on. And, I think one of the things you made the point there is that equivalence doesn't mean the same in a prison setting. And so there's a big debate about, therefore, what does it mean? And Kelly, I imagine that'll inform the deliberations based on the Nous review and the action that follows from that.